In clinical neurosurgery, resolving severe neurological deficits often comes down to addressing a failure of mechanical engineering. The craniovertebral junction is the precise anatomical intersection where the heavy base of the skull meets the delicate top of the cervical spine. This junction bears continuous, immense physical stress. When the supporting architecture beneath the cranium weakens, the entire system begins to buckle under the sheer weight of the human head. The immediate clinical result of the structural collapse is a condition called high cervical myelopathy. The collapsed skeletal architecture physically crushes the upper segment of the spinal cord. This extreme compression blocks signal transmission from the brainstem, manifesting physically as quadriparesis, severe, debilitating weakness or outright paralysis across all four limbs. The physical paralysis forces an immediate secondary consequence. The patient loses their autonomy, becoming completely dependent on their family members for basic daily survival and routine activities. While quadriparesis presents as a grim, permanent deterioration of the body, modern neurosurgery approaches it as a solvable problem. The underlying pathology driving this specific collapse is known as basilar invagination. Basilar invagination is a completely treatable entity. The cure demands precise biomechanical realignment of the skeletal structure, avoiding the trap of merely managing the resulting neurological symptoms. Correcting instability at the craniovertebral junction accomplishes two things simultaneously. It restores local joint integrity and reverses systemic paralysis. This 3D render displays the healthy, native alignment of the upper spine. The system relies on three distinct bony structures: the base of the skull, or occiput, resting on the first cervical vertebra, the atlas, which sits atop the second, the axis. The axis, C2, features a vertical projection called the odontoid peg. This peg fits precisely inside the bony ring of C1, acting as a fixed pivot point for head rotation. Above the C2 vertebra and below the large opening at the base of the skull, the foramen magnum, there is a strict clearance space. This buffer zone allows the spinal cord to descend safely from the brainstem without ever making contact with the surrounding bone. These two top vertebrae endure the continuous load-bearing requirement of supporting the skull, while simultaneously facilitating the highest degree of rotational mobility in the entire spine. A complex network of ligaments keeps these bones strictly aligned. When those ligaments weaken or rupture due to trauma, the interlocking mechanics fail. A failure in the lower back might pinch an individual nerve root, causing localized pain. A skeletal failure here threatens the central trunk of the entire nervous system. The clearance around the brainstem is exact. Millimetric shifts in the C1-C2 complex dictate the difference between normal human movement and total systemic shutdown. In this sagittal cross-section, we can identify the precise structural failure of basilar invagination. The entire cervical spine translates vertically. The C2 vertebra physically prolapses upward, and its odontoid peg crosses the threshold of the foramen magnum, invading the cranial cavity itself. The immediate spatial consequence is severe. The required clearance for the spinal cord is obliterated, and the bone crushes into the neural tissue. At the cellular level, this physical compression halts the transmission of electrical signals from the brain down to the rest of the body. This localized block at the brainstem is the direct mechanical cause of the quadriparetic weakness experienced in the patient's limbs. Left untreated, this prolapse is progressive. The constant downward force of gravity and the weight of the head continuously drive the displaced bone upward. The surgical dilemma requires moving an invading bone away from the most delicate neural tissue in the human body, without causing further damage. The mechanical displacement of the bone drives the pathology, and correcting it requires a direct engineering solution. For decades, the traditional approach was passive decompression, cutting away the back of the skull to create more room for the swollen spinal cord. Making room is insufficient. It ignores the underlying instability of the ligaments and leaves the prolapsed spine entirely untreated. The definitive solution, pioneered by Dr. Atul Goel, utilizes a posterior surgical approach. Specially designed metallic screws are anchored directly into the C1 and C2 vertebrae. Once the hardware is placed, the core mechanical action of the procedure is executed: distraction. The surgeon applies a strong vertical force between the 2 points, pulling C1 and C2 apart. Applying this vertical tension physically pulls the prolapsed C2 vertebra downward, reversing the invagination and drawing the bone completely out of the cranial cavity. The final step is fixation. Rigid rods connect the screws, permanently locking the realigned bones into their correct native position and relieving the pressure on the cord. This active reconstruction treats the mechanical root cause of the disease, moving the bone away from the nerve rather than simply removing skull matter to accommodate it. The goal technique reconstructs the native load-bearing architecture of the human spine, stabilizing the junction permanently. This split-screen comparison shows the biomechanical state of the patient before the intervention and immediately following distraction and fixation. With the physical pressure removed, the biological response is rapid. The physical pathways for neural transmission are reopened. Restoring this pathway leads directly to the complete reversal of high cervical myelopathy symptoms. In the physical world, the patient regains motor function. The quadriparesis fades as brain signals finally reach the limbs unimpeded. A patient who was once completely dependent on others is finally given their autonomy and their life back. The secondary impact is equally profound. The immense, continuous physical and psychological stress is permanently lifted from the patient's family members. Structural failures like basilar invagination present highly complex challenges, yet they are entirely solvable with precise biomechanical intervention. For medical consultation or specialized care regarding craniovertebral junction instability, contact the surgical team at AstraCura. Advanced surgical engineering restores the spine, and by doing so, reconstructs a family's future.